Thank you for the introduction. First, I want to thank the MR-HIFU team of our hospital, ISADA in Zwolle, the Netherlands, and I have nothing to disclose. The rationale of our study was first that the clinical applicability of MR-HIFU is limited due to the focal depth of the system and interposition of bowel loops. And secondly, using the classical BRB manipulation technique only, still 4 out of our 20 treatments failed due to the interposition of bowel loops not seen on the screening MRI. Therefore, the aim of this study was to decrease the screening and treatment failure rates. So when a patient enters our hospital, they go to the gynecology department and receive an enema, bladder catheter, IV line, and some pre-medication before they go to the MRI room. When they enter the MRI room, we start the patient positioning, and we have a manipulation protocol that consists of 3 steps. These are not consecutive steps, but just 3 different options that you can use if they're indicated. Option 1 is the classical bladder filling, rectal filling, and bladder emptying again. But we changed the rectal filling a little bit because instead of just using ultrasound gel and saline solution, we added psyllium fibers to that to give a little bit more power to move the fiber more anteriorly. I have 2 examples of those. So first we start at the upper left image. It's the first case where you see the screening MRI, which looked very easy to treat the fibroid, but on the treatment day, the fibroid was located more posteriorly. So therefore, we manipulated the fibroid by bladder filling and rectal filling, and we could treat the fibroid easily. The second case, we saw interposition on the screening MRI as well as on the MR-HIFU treatment day, and we did some bladder and rectal filling and bladder emptying again. And both cases were very easy to treat, and we achieved good non-perfused volumes. So the second option is a little bit new. So in the case of an enterflex uterus, you can put the patient in prone position, in Trendelenburg position, with an MRI pillow below their hips. We often perform this as step 1, but we don't achieve images at that time, so I cannot show you that example. But then we perform bowel massage at the same time. I have here an example when we did it during the treatment. So on the upper left image, you see the screening MRI, which was a very easy case, but on the treatment day, unfortunately, there was bowel interposition. So we did some bladder and rectal filling, but still there was some bowel interposition. We did bladder emptying, but that made it way worse. So we changed the position of the patient into prone position and Trendelenburg, and we performed bowel massage of that specific loop. And when we changed the patient back to supine position, you can see that the bowel loop is actually gone, and we could treat the patient very well. The third option is even newer. So in the case of a retroflex uterus, we perform uterus displacement manually. At that time, we give an extra shot of propofol so that the patient is not in any discomfort. And we fixate, if necessary, the fibroid and the uterus in the enterflex position with a speculum. I have 2 examples of those. This was our first case, actually. It was a very young patient with still a desire for future fertility. We performed bladder rectal filling and bladder emptying again, but there was still a bowel loop that was in the way. So we did a little bit of more bladder filling, and then we manually manipulated the uterus from retroflexion to enterflexion, and we fixated it with the speculum that's from plastic, and it stayed there the whole treatment. We were a little bit time limited here because we do 2 treatments a day, so we only achieved an MPV of 80%. The second case had a screening MRI of a retroflex uterus with a fibroid, and we did some bladder and rectal filling, but it was not sufficient enough because there was still some bowel interposition, so we manually manipulated the uterus forward, and we could easily treat this patient as well. So the results so far from our manipulation protocol, there were no thermal complications to the bowel or the uterus, and our treatment failure rate due to the interposition of bowel loops decreased from 20 to 0%. Our screening failure rates decreased from 53% to 28% because now we include all the patients with a retroflex uterus or bowel interposition. There are still some screening exclusion criteria left at our center. We cannot manipulate pedunculated fibroids that are not ventrally located because if we move the uterus forward, the fibroid just stays where it is. An excessively high T2 signal on the MRI is still a huge problem, so we cannot treat those, and a large size of number of the fibroids. In conclusion, after implementation of our manipulation protocol, consisting of the BRB, manipulation, Trendelenburg, and uterus displacement, we saw a decrease of 20% in our treatment failure rates and a decrease of 25% in our screening failure rate. So thank you for your attention, and I'm happy to receive any questions.
Question?
Can you tell us what the bowel massage actually consists of?
Yes, I can.
Perhaps a demonstration.
The demonstration is that when the patient is in prone position, we just start at the bottom left, or where the bowel loop is, left or right, and we just go very hard. We move to the upper side of the thorax.
You go very hard.
Very hard, sometimes with the elbow. No joke.
Hey.
I can tell you that sometimes in our patients, we actually get them off the table, put them in a down dog position, like a yoga position, and we literally massage those bowel loops. And if they're skinny patients, you can actually feel them and
You can feel them.
and watch them move. So
do I have a feeling this is something that only ladies should do?
that's okay.
I think I'm just going to
I'd like to ask you a quick question. How many patients were in each category? How many patients were you able to do with just stage 1 versus the second option or the third option?
So stage 1, I feel like we almost always perform stage 1 in some kind of way, except when the fibroid is really large, then there's no manipulation necessary. The Trendelenburg, we always start with that if we suspect bowel interposition, but then it only takes you 5 minutes because you just put them before you put them on the MRI table. But we use it the least during the treatment because it's time consuming, because you have to change the position from supine to prone. And the uterus manipulation, we're using it quite often now because it's just way faster and it works very well. It takes you 5 minutes if you know how to do it. And it saves you a lot of treatment time.
Okay, great. And I think her data is really important. If you spend the time before the procedure to get the uterus in a satisfactory position, the rest of the treatment goes much better and you get a higher NPV and the patient does better. So to spend the time before the actual treatment is so important. So thank you for your data. Thank you. Oh, sure.
Those bowel massage, I was pretty impressed because we tried and we are not really succeeded. Were these patients very thin or they are pretty overweight?
No, that doesn't matter actually, but the thing is we do a lot of rectal filling, quite a lot, because we start with some ultrasound gel, I think 3 syringes of 60 milliliters, and then we just go on with our special mix. And that's another like 240 milliliters. So the bowels that are before the fibroid are often filled. So then you can feel them easier. So you feel the like filled bowels, and then you massage them out of the way. It doesn't matter if they're thin or a little bit fatter.
Good. Okay.
Very good. Okay.